Hello, welcome. Hello, everybody. Good morning. I'm Talia and really pleased to be a facilitator today for today's special webinar, proudly hosted by the Eczema Association. Webinar today is the eczema patient journey from first symptoms to specialist care. So that's why we're all here today. A lot of us have been touched by eczema or know someone that experiences it, or attendees joining us today from all across Australia and New Zealand. You're welcome to pop your hand up, let us know where you're from. Today's session is all about practical insights into the eczema patient journey, early symptoms and diagnosis, referral, specialist care, and treatment planning. Everyone here feel more informed, supported, connected, confident, in navigating the healthcare journey for yourselves or someone that you're looking after. So you're welcome to use the chat, say hello, introduce yourself, shout out where you're from. 35-minute presentation at the end. And you just need to stay through till the end. And from the Eczema Association, he's the CEO of Eczema Association in Australia and New Zealand. And leads the association's advocacy, education, and support efforts across Australia and New Zealand. Vanessa Jenkins from Eczema Association in New Zealand. Dr. Adrian Mar is a dermatologist and digital heads up the digital dermatology. So he's based in Melbourne. He's a co-founder of Digital Dermatology, an online telehealth platform, access to specialist dermatology care across Australia. Former head of Department of Dermatology at Monash Health for 18 years. Adult and pediatric dermatology services, a dedicated pediatric eczema clinic. So today, Adrian will guide us through all of these questions we might have, some of the key aspects like what's the value of really being recommended to a skin specialist and what's the outcomes that you might expect from that. And, our ultimate goals in treatment and specialist care. So I'd like to say, we're thrilled to have you all here.
Thank you for everyone that's joining us from all around Australia. I'm Vanessa Jenkins, who is our advocacy rep. She's based in New Zealand. And Talia from Social Mums Club. And thank you so much, Associate Professor Adrian Mar, Dr. Mar. I'd like to acknowledge the Kondamuka people, the traditional custodians of the land that I'm joining you from today, and pay my respects to their elders past, present and emerging. Advocate for treatments and care, and for a community where everyone living with eczema can feel supported, understood, seen and heard. We're here to help, and we really do believe that no one should have to face eczema alone. So all of our contact details are on our individual websites, which is eczema.org.au and eczema.org.nz. We'll show you those later. So please don't hesitate to reach out to any one of our team. Eczema can be a really complex, frustrating condition to navigate, especially in those early stages. Understanding what to expect, where to get support, how to access the right care, all of these things can make a really meaningful difference. So today's webinar is really going to focus on that patient journey. Will be followed by that Q&A session. So while Dr. Mar is talking, if you do have any questions, please pop them in the chat. We'll make sure that we come back to you following the webinar. You'll also get a recording of the webinar, so no need to write anything down. Sit back and relax and enjoy. So across Australia and New Zealand, this is the trusted logo that you'll see on a lot of packaging in the pharmacies and Coles and Woolies and online as well on lots of websites. So please do look out for this logo. You may see different versions of it. Some of them may say gold, silver or bronze, but essentially this logo says that the product has been assessed and suitable for eczema prone skin. I think now it's time to pass you over to Vanessa.
Can everybody see that okay? Thank you everybody for being here. I really love being able to jump on these things and just, really connect with the community. That's something I'm really passionate about, and to make sure that we're getting the right support to everybody. So the Eczema Association of New Zealand, we've got lots of things in place. We've got a membership. So ours is primarily digital here in New Zealand. And on the website, you have just got so much information available. At the moment, it's only $5 for the year. The amount of information and support that you can get through this membership is next level. If you're a member, you get access to over 70 information sheets, and they are building every month. Anything you can think of that is specific to eczema, any questions or anything like that, 9 times out of 10, they're going to be in there. And if it's not, then you let us know and we're able to find out and let you know as well. And we have our quarterly magazine, which is absolutely chock-a-block full of lots of patient stories, tips and tricks for seasonal flare-ups, things you can do in certain situations and all that kind of thing. So part of what I do is bringing the advocacy aspect to eczema. Eczema is such a common disease area and something that affects 1 in 3 families actually in New Zealand at the moment, and across Australia. The statistics might be a bit different, but it's having the voice, the lived experience, and being able to sort of share that level of connection with the community is something that I'm really passionate about. I've been caring for my husband who has atopic eczema for 15 years now. And so I understand, and I understand what it means to have eczema for people in their lives. And I think part of the advocacy journey for us has really been to bring a voice to the people who don't have one and make sure that we are promoting new treatments and for those things that we don't have access to at the moment in New Zealand. So we like to listen to the community. If you guys have anything that you are wanting to sort of discuss around treatments or advocacy voices and things like that, that's something that we're really looking to get our cooks stuck in over the next couple of years. I've spent the last few years talking with Pharmac, government. I've been abroad and sort of learning more about what other countries do in terms of their advocacy and how they help promote treatments, how they work alongside their governments to be able to bring new treatments and things like that into the community. And part of that is also sharing the lived experience of people. So we'd love to hear your story, things that you've been through with your eczema, because at the moment it's all about creating a shared voice and making sure that that's heard. So that's something that's really important to us here. And then, so I've pretty much just said it, but why advocacy matters. Advocacy isn't abstract. It is about improving access to effective treatments, strengthening care pathways, and improving the quality of life. So what we do at the Eczema Association is provide you with information and making sure that you're not feeling alone and knowing that other people are going through what you're going through as well. Just to let you know, you are not alone in this, and we are here to help you. Any questions that you've got, reach out.
We'll just hear directly from Dr. Adrian Mar now. You're welcome to go. Welcome.
Well, I'll get straight into it. So there's a number of things, there's so much I can talk about with eczema, but the first I think really is, where does a specialist fit in? And I just want to give some general principles about eczema or dermatitis. It's the same condition. I think applies to all cases, given that we see mild, moderate, severe cases and different presentations. So the first with regards to specialist, I'm very aware that access is a problem. So even though I'm going to tell you where I see specialists adding value, there are genuine access problems here in New Zealand. And not everybody has a local dermatologist. And not everybody, even if there is one, can get in straight away. There may be a month's wait. And the other is cost. It's expensive to see a specialist. So very aware of these issues. And I'll mention at the end one way that we're trying to address that. So in terms of where the dermatologist fits in, most eczema, I think, is properly and adequately managed at the GP level. GPs have got the hardest job. They have to know a bit about everything. But I think most people have had an experience where they've been prescribed a cream or ointment. It hasn't really solved the problem and it keeps coming back. And I have to admit, a lot of people have had experience seeing a specialist or thinking about seeing a specialist, thinking, well, they're just going to prescribe the same cream or ointment. What additional value can I really get? So I think an analogy might be that if you or your child fell down and broke their wrist, a doctor could say, let's put a plaster on. And if the doctor said, put the plaster on, which is appropriate treatment, and then just left it at that, there was no follow-up. Well, you'd be thinking, well, hang on, how long do I have to keep it on for? What do I do after the plaster comes off? Is there going to be any risk having the plaster on? Can they use their arm? So it's a little bit like seeing a doctor and they say, here's a cortisone ointment for your eczema, and that's it. So this, I think, is really important when it comes to where specialists can come in, because that's only the first step. Eczema is a very complex disease, and there's a lot to sort of get our heads around. So I just want to go right back to the cause, because that's the first thing we always think about. But I do want to give a little bit of perspective, because I wish it was as simple as saying, don't eat tomatoes and the eczema will disappear. We all know that that is not the case. So for most people, the focus really needs to be on treating the eczema, getting it better, because we all do think about, is there a root cause? We do as specialists, believe me. But the reality is that for the large majority of people, it is a genetic predisposition, and we have to, at the end of the day, focus.
Has anyone else lost him there?
On getting the eczema better, because we can. None of us can change our genes. Yeah. Now, there are some environmental factors that we can influence, particularly with dryness of the skin. So if people are not genetically prone to getting eczema, which is a lot of us, if we have dry skin, Melbourne's a very dry climate here, the heaters go on and make it worse in the winter. If I get dry skin, that's just dry skin. Now, there's a whole industry out there, I know, including a lot of our supporters, who sell moisturizers, and that's great. But if I have dry skin, that's as far as it gets. However, if I'm genetically prone to getting eczema, that dry skin can trigger off my eczema. And so that's why moisturizing is absolutely key. Diet, you can't, as much oil as you drink, it doesn't come out into the skin. And so if somebody, a little baby, might be prone to getting eczema, well, then regular moisturizing of the skin to prevent that first step of dryness may help to prevent that child developing eczema or severe eczema. So moisturizing is really important. Little babies, I don't like using oils. We certainly don't want anything slippy around the place. I mean, some bath oil is okay. Now, having said that, you can do all of that and your child can still get eczema. It is not your fault. And that is so important to know. So it's not mum's diet. It's not what you're feeding the child. We'll touch on food, if we've got a little bit of time. But the bottom line is that we don't want to focus too much on food. Again, because it's not usually as simple as that. But very importantly, a child needs nutrition. And the worst thing we want to do is to deny a growing child certain nutrients or food groups that they need, and there can be other health consequences. So we have somebody who has, for genetic reasons, we assume, developed eczema. So what is going on there? It has all to do with the immune system. I mentioned the barrier function with the dryness triggering off the immune system. But once the rash develops, whether it's the red scaly rash, which is typical, whether it's oozing, whether it's blisters, these are all variants of eczema. But it has something to do with the immune system. Now, our immune system is very, very complex. And the first thing to note is that although there is a small part of the immune system that is overactive and coming into the skin, and we don't know why. So let me just drill down a little bit on that point first. If we biopsy the skin, we don't have to, we can normally tell clinically it's eczema, but what we would see in that top layer of the skin are a whole lot of white blood cells. Now, white blood cells, and there are many different types, are a part of our immune system. What they should be doing is fighting infection and actually fighting cancer as well. So when there's a very small part of the immune system coming into the skin, making it red and scaly, itchy, and we don't know why, there is no reason, there's no infection to bring the eczema into the skin. That's what we call inflammation. So inflammation in medical terms has a very specific definition, which is to do with the immune system, whether it's inflammation of the liver or the joints. A small part of the immune system is misbehaving, coming in there, don't know why. So the focus really is to get rid of those immune cells. Now, I was going to say that the immune system is not as simple, because it's not as if the immune system is too high or too low. The last thing we want to do is to use immune boosters. Now, truthfully, stuff that you buy over the counter for that they say immune boosters don't really boost the immune system, but there actually are true immune boosters in treating melanoma. There's amazing drugs that actually stimulate the immune system to fight off the cancer. Now, that's a full-on immune booster, and that will make eczema 10 times worse. So we don't want to boost the immune system. But when we think, well, eczema gets worse with stress, which it does, doesn't the immune system go down when we get stressed? Well, the answer is yes, parts of it do. So it is true that when we are under stress, parts of our immune system go down. We may be prone to certain infections, maybe, and every person's immune system is different. But almost all conditions I see, whether it's eczema, psoriasis, alopecia areata, vitiligo, which have all to do with the immune system, they all get worse with stress. So what's going on there? So in other words, stress is dampening down some parts of the immune system, but other parts go up, including in eczema. So it's not a simple thing. So I think I just make that point because in eczema, our focus is trying to get rid of or dampening down that very small part of the immune system. A very important principle, which there is now gathering research evidence to support, is getting rid of that immune reaction as soon as possible. So the way that our immune system works is that if there is a germ, the immune system doesn't just fight that, but it recruits other white blood cells into the battle. The immune reaction gets bigger and bigger. And then when the germ has gone away, the immune system remembers that and is ready to fight the battle the next time. But the immune system is designed to feed off itself. In eczema, we don't know what's driving those immune cells to the skin, but those immune cells themselves are not just causing that inflammation. They are recruiting, calling on the immune system, bring more of these immune cells into the skin, as if there's infection, which there's not. So if we leave eczema untreated, the problem is that it can be harder to get under control. So the converse research support, not just in eczema, but other inflammatory conditions. If we get rid of that immune reaction at the earliest possible stage as completely as possible, we may actually be preventing longer term, more resistant, harder to control eczema. So we feel that there is an opportunity to impact a person in a positive way by trying to get on top of that inflammation as early as possible. So how do we do that? And that's really the key question. Specialists do have a role, particularly when it comes to going beyond the use of cortisone creams and ointments. But a few important principles. I've already touched on one, which is to get rid of the inflammation completely. So going back to the plaster on the arm, how long to keep the plaster on the arm? Well, usually it's 6 weeks or something. So there is an endpoint. And it's the same when applying a topical steroid. That endpoint will vary not just from person to person, but in the individual. Some parts of the eczema may need the cortisone ointment for a shorter or longer period of time. But the endpoint for treatment is to get rid of that spot. Now, what I mean by that is we certainly want the itchiness to have gone, the redness to have gone, but the best way to judge that is the feel of the skin. We know when we feel the skin and eczema is active, we can feel it being rough and bumpy. There are some forms of eczema. The lumpy form of eczema is the most resistant. It will take a lot longer for that skin to become smooth and flat. Standard eczema, red scaly rash, we treat with the cortisone ointment, once a day, twice a day, doesn't matter, until in a few days the itch is gone, but we don't stop. We keep going until, if you were to close your eyes, feel the skin feels smooth and flat. If the skin is dark naturally, there might be a bit of a stain, but that's fine, that'll settle. But the feel of the skin is a very useful endpoint for treatment. In most cases, using a cortisone ointment every day for 2 to 3 weeks, sometimes even 1 week, will be enough. For that thick and lichenified eczema, it may need to be 4 to 6 weeks, sometimes even a few months. So we have to consider what the downside risk is. Thinning of the skin is the risk. And when the skin's thickened up, that's not a bad thing. We want it to thin the skin. How long does it take to thin the skin? Well, if you use a prescription level cortisone ointment and apply that to the same area constantly without stopping for 1 year or more, it may thin the skin. Now, that's a long time. In somebody who's very old with thin skin already, that might only just be 2 months. Thinning skin presents as easy bruising, stretch marks which are permanent, or the skin can appear a bit translucent. So we don't want that to happen. But if we apply even a very strong cortisone ointment every day for 3 to 4 weeks and stop, that will not thin the skin. If we then use it as maintenance, 2 applications only per week over a long period, that will not thin the skin. So we do want to avoid everyday application for long periods of time. Now, some other principles. So if that's not enough, we go up to phototherapy, which is available through dermatologists, and that sometimes can be very helpful. It's a very safe treatment, not always effective enough. The next above that is what we call systemic therapy. So here we're talking about a tablet or injection, Dupixent, into the body. So I just want to make a point just before I finish. Immune suppressive therapy sounds scary. It isn't black or white. It's not as if immune suppressive therapy is all good or all bad. The role of the specialist, the role of a doctor, is to treat adequately the person in front of us, whether it's a big person or a little person, but not to put a person at risk of serious consequences or side effects. That's our role, that's our responsibility, and we do take that seriously. So any immune suppressive agent that's been considered by a doctor is not, well, it's been through many clinical trials. There's usually a lot of experience published and professional experience. We know that the doses that we would use are safe enough so that they don't damage the immune system to put people at risk of infection or things like cancers. In fact, studies confirm that the safety of these medicines is much greater in children. The people that are at highest risk of immune suppressive therapy are older people. Their kidneys or liver are already a bit old. They're much more vulnerable if we dampen the immune system a little bit. Children actually tolerate them very well. And yes, there is a need for some, particularly the tablets, to do some blood tests to check the kidney or liver. But that's part of us managing that very small risk. You would want your doctor to take into account all of the risks possible. And that's a part of that, and it's part of having discussion. So generally speaking, if a person needs immune suppressive therapy, and again, I go back to the point, that it's very important to switch off the immune system as completely as possible, but it's got to be done in a safe way. Then we're generally talking about treatment for 2 to 3 years. It's not going to be forever. But if we can switch off that immune system completely, then it's a question of time before that immune system slowly over years starts to calm down more and more and more. And eventually the plan will be stop the medicine completely. And by that stage, hopefully the immune system's calmed down enough so that it doesn't keep coming back. But it does take time, and we're talking about a period of years before that immune system calms down. But people are not really going to be expected to be on it forever. The injections, I have to say, are so safe that people can be on forever. So I think that's probably the main points. There's so much more that we can talk about, and I know there are questions, and I did want to leave some time for questions.
Thank you. Even just your chat there answered some of the key questions that were coming through. There were a number of questions around immunosuppressants and causes and things like that. There might be one or two around the link between eczema and perimenopause stress or puberty in younger ones as well. So I guess more hormonal and then stress related. What's your thoughts around that? And would they approach it in the same way?
Yep. We would think that the menopause is associated with a lot of changes with the skin, but I can tell you as a dermatologist, surprisingly very little. And when it comes to eczema, no, I don't believe that there is anything beyond maybe the skin getting a bit dry, but we don't typically see that. What we do see is people getting, when they're quite old, and that oil glands are really shrinking, the skin gets dry, and that can trigger off eczema. Puberty, in fact, often improves. I mean, one reason why eczema often improves from childhood to adolescence is the skin becomes oilier. Stress is definitely a trigger. And there's only so much we can do. And of course, it's a vicious cycle, and that eczema itself is stressful.
Margaret emailed in, we have a 10-month-old who's had eczema since 8 weeks, and that one or two of the ladies in the chat here have young ones just a couple of months old or a few months old, struggling to control acute flare-ups without steroids. Just one of the key questions, what would be your criteria for asking to have a referral to see a specialist for a baby with eczema?
So thanks, Talia. Now, this is actually a really important point. There is one group that we are much more careful with the use of topical steroids, and that is babies or young infants. Now, there are very important reasons for that. Firstly, the skin is thinner, so some of that cortisone could get through the skin. The second is that if a little baby is covered all over with eczema and we put the cortisone all over their body, then the amount that we get into the body is actually greater because the body size is smaller. So treating significant eczema in children, having said that, cortisone ointments are very safe in even babies, but it is very, very important that that is done under specialist care. In other words, we need to hit it hard and try to get rid of it with a cortisone ointment, usually a mid-strength ointment. We prefer ointments, not creams. Using that every day until it clears. A 3-week period is okay. I mean, we do use oral steroids even in infants for various things, and we know using that for a month or even 2 months is okay, but we certainly don't want to keep going for months on end. And if we only half treat eczema, we only treat for a few days, it keeps bouncing back. We actually can end up using more cortisone. So it's much better to hit it hard in the beginning, try to get rid of it completely, and then to moisturize. Moisturizers don't really play so much of a role when the eczema is active. I like to think of eczema being treated in the treatment phase, the first phase to get rid of the rash, and maintenance, stopping it coming back. Maintenance, that's where moisturizing is really important every day. But during the treatment phase, we need the cortisone ointment or tacrolimus, which is a non-cortisone, to get rid of the eczema completely, don't half treat it, and then we can go into maintenance. So for little babies, I think very important to, firstly, cortisone ointments under supervision are safe and necessary. The mid-strength ones, but as I said, we are just a little bit more cautious about longer-term use.
Yeah. Thank you. I saw another couple there relating to working with a naturopath for and gut health and looking at things like that. I know there's a lot of talk around and I guess you mentioned about inflammation being parts of inflammation being a bit of a driver there. If there's things like food intolerances or things like that, what's your sort of stance on looking at that aspect holistically as well as potentially topical treatments?
So maybe I've got a biased population. I see people who've tried all of that and it just hasn't worked. And I think, although no harm, I'd be definitely cautious about, food elimination diets because of the nutrition aspect. The ideal situation if a child has severe eczema. So my general approach is we do the standard therapy for eczema, which is a cortisone ointment, try to clear it. And if we do and can maintain it with moisturizing, then hardly ever need to use a cortisone ointments, then that's a good outcome. We don't need to do anything more. In the very severe cases, we do all of that, we try our best, and it still keeps coming back. Now, sometimes there is a role there to involve a dietitian, an allergist, to talk about food, and really we always say to people, just observe, are there any foods that seem to make it worse, to avoid that. I wish it was as simple as doing prick testing or whatever. Again, the prick testing doesn't correlate exactly with eczema. I certainly would cautious against relying entirely on alternative options. Although they can be considered, I would firstly always suggest conventional therapy, which is what your doctor would advise, and those other things as well. But particularly we're dealing with eczema that's a bit more stubborn. Even if there's a small impact there, it's usually not going to be sufficient.
Thank you.
I'm very aware that it's not to be seen as sort of promotion of the service that I run, because I want people to be aware in Australia anyway there are other telehealth dermatology services. But the thing that really did drive me to set up digital dermatology is access, and that means that we need to get people to be able to see a specialist as soon as possible for those people with very severe disease. And I'm extremely delighted that one of my colleagues, who is one of Australia's experts in paediatric eczema, so she's head of the department at Westmead, where they've got see paediatrics as well. Her name is Li Chun Wong. She's a lovely, lovely doctor. So she's a part of digital dermatology, and we really aim to provide people an appointment within a few weeks to see her. The other thing that we're trying to do. You don't need a GP referral, but you can get a rebate if you do have a GP referral. The other thing is cost access. Now, it is expensive to see a dermatologist. I am very keen to be working with Ange and the EAA to see if we can develop other models that might make particularly follow-up more accessible, whether that's with a nurse-doctor team, whether it's group sessions. We need more around education online resources. So just to let you know that I'm, yes, very mindful of the need here, particularly with people with very severe eczema that need specialist level care. New Zealand, we have to have a discussion about that, Vanessa.
I've got another one here that could be quite helpful for people. So you mentioned that often eczema symptoms can be genetically predisposed and relating to misbehaving immune system. Are there any other triggers that or causes that are often seen that sort of, can ignite that? What should people look out for, I guess, as triggers or causes as well?
Yeah. So if the skin is, let's say, the eczema is adequately controlled, the classic triggers are heat. So avoiding hot showers, keeping the heaters down in the winter. The reason why eczemas are often worse in the folds is because the sweat in front of the elbow folds can irritate the skin. So heats will make the skin more inflamed and itchy. When we bring children into hospital, we put wet dressings on them. We actually want to cool the skin down. So coolness is the key for itch and to help settle the inflammation. Avoiding long hot showers because that washes the oil from the skin as well as overheats. Avoiding soaps, we don't want to dry the skin, so soap substitute is important. Cotton clothing only. Children removing the labels from the back of the clothing. Other irritants, sometimes in the sand pits, grass, sometimes even allergic component there. Irritants generally. When eczema is inflamed, even water and moisturizers can sting. The thing there is that's not an allergic reaction. We need to get rid of the eczema. Once the eczema is cleared, moisturizer could be tolerated and the skin less sensitive to water. So I think they're the main things. Stress certainly can be a trigger as well.
Thank you so much.
There are so many questions and so many great questions in the chat. We will respond to those and we will come back to you all because, there were some amazing questions there. So if you're, if eczema does impact your life, our support services, our free resources on both of our websites and our annual membership that Vanessa touched on is available to you all. These telehealth dermatology services with the reduced wait times are, incredible. The wait times, and the cost to and accessibility of care, can often, be a huge barrier. So whether you're, newly diagnosed, whether you're, looking after a child with eczema, or if you're just managing your own eczema, our job is to make sure that we can give you lots of trusted information, practical support, tips and tricks, resources, and we really want to make sure that you feel informed and supported in that journey. So inside of our membership portal, we've got so much information. We add more content every month. We've got digital information sheets. I think Vanessa said 70. I think it's probably close to 100 now. We keep adding to those. Every month we try and give you more information. You get all the webinar recordings, not just this one, obviously, but all previous ones. Bonus resources, recipes, the Living with Eczema magazine, which we are so proud of. That's a quarterly magazine, so you'll always get the current edition, but you've got the full back catalogue as well. Highly recommend having a read. There's some great expert articles in those magazines for you there too.
Thanks everyone for coming and attending, participating. Thanks for being here. Take care of yourselves. We look forward to seeing you at the next webinar.
Thank you, everyone.